My name is David Linker, and I'm pleased to summarize our study, Selective Screening for Atrial Fibrillation using Multivariable Risk Models. Atrial fibrillation is a specific irregular rhythm of the heart. Up to 1/4 of all first strokes are believed to be caused by atrial fibrillation, or AF. More than 1/3 of those were not known to have AF before the stroke. AF is the most common heart rhythm disturbance that requires treatment, and risk factors can identify those with AF who need treatment. Treatment can dramatically reduce the risk of stroke. The problem is that AF can be present intermittently but may not cause symptoms, making detection difficult. Additional cardiac monitoring can detect AF. But to be cost-effective, the additional monitoring should be reserved for those at elevated risk. So, who should we screen? Recent European Society guidelines from 2016 recommend screening everyone over the age of 65. A number of risk models for AF have been developed which may do better than age: ERIC, Framingham, Hatch, WHS, Charge AF, and Mayo. As part of the current study, we developed a new atrial fibrillation risk score model for an ongoing study called Screening for Asymptomatic Atrial Fibrillation Events, or SAAFE. The SAAFE risk model was based on self-reported information on AF and other cardiovascular conditions from subjects in King County, Washington State, collected as part of the Monitoring Disparities in Chronic Conditions Study, or MDCC. There were a total of 3,790 subjects from two cohorts, one random address-based and the other based on screening medical records for treatment for specific medical conditions within 2 years. The developed SAFE risk model relies solely on self-reported information. The prevalence of AF was strongly associated with the resulting SAFE risk score, as you can see in this graph, ranging from less than 2% in the lowest risk category to greater than 60% in the highest risk category. We used data from ERIC to validate the model and compare it to the other models. In ERIC, subjects were called in for an examination every 3 years, contacted by telephone every 6 months, and there was community surveillance. We used all these sources of information. We collected all data up to and including exam 3 as baseline data for calculating the risk using the various models. We then collected data from after exam 3 up to and including exam 4 to determine new onset atrial fibrillation. We then compared the ability of the various models to predict new onset AF. 5,723 of the subjects would be at elevated risk of stroke if they developed AF. A total of 117 of these developed AF over the following 3 years. 2,548 of the subjects were 65 years of age or older. The thresholds of the risk scores were adjusted so that each would screen the same number as the age criterion. This graph shows the results as a percentage of those who developed AF identified. 4 of the models, including SAFE, performed significantly better than age alone. We conclude that multivariable risk models can perform better than an age criterion in identifying those at risk for developing atrial fibrillation. A model using only self-reported information, SAFE, performed as well as other models requiring additional tests. A strategy using a risk model could be incorporated by physicians to more effectively screen for atrial fibrillation than using a simple age-based criterion. To read the entire article, go to the journal Heart. Thank you for your attention.